Should I give a brief reintroduction of myself? I'm
Yes. Sure.
Sure, that would be
John
great.
McKensie. I'm a cardiologist in Glendale, and my practice is limited to electrophysiology, which is a subspecialty of cardiology. So in cardiology, we first train in regular internal medicine, then we typically do 3 years of general cardiology, and then electrophysiology is another 2 years typically of additional training. And so we deal exclusively with heart rhythm disorders. Some of those are rapid rhythms that are of the upper chambers of the heart, like, for example, atrial fibrillation, which we'll be discussing. Some of those rhythms are from the lower chambers, and those are the life-threatening ones that cause cardiac arrest. The range of procedures that I do include catheter ablation for multiple types of arrhythmias, and insertion of specialized cardiac rhythm devices, from the spectrum of pacemakers to cardiac defibrillators to resynchronization pacing devices that are for patients with advanced heart problems and heart failure. So that's kind of the spectrum of my practice. I've been increasingly interested in stroke, and so I'm pleased to have the chance to speak today, because it's a devastating and common medical problem. And it's in a very transitional phase right now, where finally there are very talented interventional doctors who can manage acute strokes and improve the outcome. And it really intersects with cardiac electrophysiology, because one of the more common problems that are referred to me is a heart rhythm problem called atrial fibrillation, which is highly associated and a major cause of stroke. So this has sort of brought me into the fray to help and co-manage patients who have a stroke. So I'm going to, my talk will basically be the relationship of atrial fibrillation and stroke. And
I'm going to share the screen.
Yeah, but if you go, okay, yeah, share the screen.
Right. So now we're going to.
So the first, so everybody can see my screen, correct? It should say atrial fibrillation and
Yes.
stroke in blue.
Yeah. It's
Yeah,
perfect.
and before we continue, could everybody open up the chat, because that's where you will be putting questions to the doctor at the end of the presentation. So make sure you open up your chat so that, and I think Michelle already opened yours, Dr. McKensie.
Okay, all right. So we will move on. So when we talk about causes of stroke, and Michelle informed me that many of you had the opportunity to listen to lectures or presentations by two of my colleagues, Dr. Bader and Dr. Gregorian, as this is Stroke Awareness Month. So when we talk about stroke, there are 3 basic mechanisms or causes. And so one of them is good old-fashioned atherosclerosis, which is the same disease that affects the arteries of the heart. It can affect the arteries of the legs, where it leads to claudication and complications related to not getting enough blood flow to the legs. And in the heart, of course, you're all aware of patients getting a heart attack. Some patients may need stents, and then some patients may need open heart surgery for revascularization. So, but the disease process is the same, whether it is in the leg arteries, the heart arteries, or in the blood vessels that supply the brain. The large vessels are the carotid arteries, but this atherosclerotic plaque obstructive artery process can also extend into the arteries that are inside the brain itself. The middle cerebral artery is one of the more common ones that you may hear about. So mechanism or cause number 1 is atherosclerosis. And the risk factors that apply for this type of problem throughout the rest of the body, the heart, for example, smoking, diabetes and high blood pressure, et cetera, those risk factors and those treatments apply for this mechanism for the heart, the treatment being lipid lowering medications and aspirin. Now, the second mechanism, generally speaking, relates to chronic uncontrolled high blood pressure, hypertension. And what this does in the small arteries, the tiny terminal arteries inside the brain, is it leads those little arteries to basically sclerose down, harden, and then basically the lumen blocks off, and that leads to a stroke. And these have a specific name that sometimes you may hear about, lacunar strokes, and that's uncontrolled high blood pressure. That's the second major mechanism. And then the third is thromboembolic. That's a medical term that means thrombo refers to a clot, and then embolic means that it breaks off from someplace and floats up to the brain, thromboembolic. And the vast majority of these come from the heart. There are sources of embolic clots that can come from the aorta, for example, the large artery of the chest right outside the heart. But the vast majority of these come from the heart. And well over 95% of these are related to atrial fibrillation. There are a few rare other causes where a clot could form inside the heart related to a valve problem. Sometimes there are tumors in the heart that can generate this. Sometimes if someone has an extremely weak lower chamber of the heart, the left ventricle blood clot could form there. But again, for practical purposes, cardiac thromboembolic mechanism essentially means atrial fibrillation with the clot coming from the atrium. So atrial fibrillation is an abnormal cardiac rhythm. So if you look at this slide, the normal rhythm begins in the top of the heart, the atria, and it begins in a very specialized nerve called the sinus node, which is why normal rhythm is called sinus rhythm. And the impulse propagates through both upper chambers, and then they contract simultaneously. And then the impulse transmits down a specialized nerve going to the lower chambers, and then the lower chambers beat. So the normal rhythm, sinus rhythm, is an extremely efficient rhythm. There's coordination between the top and the bottom. And then there is also an appropriate rate range. The rate is physiologically appropriate for the activity. If you're sleeping, the rate will be lower. If you're sitting at a table or doing sedentary work, again, the rate will be a little higher. And then when you exercise or do any activity, there's a proportionate increase in the rate. Now, atrial fibrillation is an abnormal nerve disease of the upper chambers. So it is not caused by other heart problems. For example, it's not caused by blocked arteries or other diseases of the heart valves, for example. Its root cause is mainly a genetic electrical abnormality, a predisposition for areas, particularly of the left atrium, to develop enhanced abnormal electrical activity. And rather than a normal nerve focus like the sinus node, which gives normal coordinated electrical activity, these nerves, when they turn on, they fire erratically and rapidly, 300 times per minute. So the atrial rate, or the rate of the upper chambers during atrial fibrillation, is over 300 beats a minute, which basically means there's no contraction. It also means that many of those signals will transmit down the AV node, the connecting nerve, and then the lower chamber rate will be rapid. Usually it will be in the 70s to 80s minimum at rest, but it will immediately go very rapid with any degree of activity, and it will race fast, it will pause, it will speed up again and pause. Patients will typically give a sensation that they feel their heart jumping, they feel it beating erratically, and so forth. In addition to the rapid rate, there's no contribution of contraction from the top anymore. There's no contraction. And so each heartbeat has a proportionately lower amount of blood coming out per beat. And also with the rapid rate, there's less time for the heart to fill in between heartbeats. So the net effect is that it's a very inefficient rhythm. And so the amount of blood going out with each heartbeat is decreased. The amount of blood over a period of time going to the tissues in the body, the organs, is decreased. And then blood may back up in the lungs, and then that creates a little bit of fluid leakage and a shortness of breath sensation. So the symptoms are typically shortness of breath, a feeling of palpitations, a feeling of fatigue, perhaps lightheaded, and so forth. Now, and the symptoms may be mild, but they may be severe in some patients. It may lead to chest pain, which means that it's stressing the heart substantially. The blood pressure may lower. Patients may get to a point where they're about to black out. And then these patients require attention in the emergency room. Now, a certain percentage of patients experience very few, if any, symptoms. And I will make a comment that even those who feel that they have no symptoms, there have been studies when their rhythm is restored back to normal, around a third to half of them will say, well, wait a minute, now that I'm in normal rhythm, I do feel different. So I like the term minimally symptomatic rather than completely asymptomatic, but there's definitely a population of patients with atrial fibrillation who don't feel it that much. And the reasons are their heart muscle is able to compensate, and often the patient may mitigate their activities. So they kind of avoid those activities that really tax the system. So the first clinical issue regarding atrial fibrillation is the symptoms. The second is the damage to the heart muscle. And this is more of a longer term process, but basically the effects of a rapid rhythm on the heart, racing it, slowing it, racing it, it tends to wear the muscle down. And in a certain percentage of patients, their heart function will deteriorate. And then the third clinical problem is where we are today, is the risk of stroke. And then how does that happen? Well, we talked about during atrial fibrillation, the upper chambers essentially lose their mechanical contraction. Now, basically blood is always kind of whooshing into the upper chambers from the lungs and then going to the lower chambers and then out. But there is a structure called the left atrial appendage. And this is an area that is essentially a pouch on the outside of that connects to the left atrium, which is the upper chamber that is exposed to your systemic circulation. This pouch can, in some patients, be kind of a nice little globular thing, but in other patients, there are lobes that extend down or up, and then there are trabeculations in those lobes. And so blood coming in during the normal rhythm, because there's contraction, will be ejected out of here. But during atrial fibrillation, the blood will pool in here, and this is a setup area for clots to form. And it does turn out that well over 90% of blood clots from atrial fibrillation come from the left atrial appendage. Now, a common question is, why do we even have a left atrial appendage? There are some physiological functions of the appendage. It secretes certain hormones that help with sodium and water retention. It also serves as a reservoir for acute deteriorations of the heart. So the blood can go into the appendage rather than going into the lungs. So it does have some function, but unfortunately, it also has a major clinical negative issue with its association with stroke. And this is one of the ways that we image the appendage. This is called a transesophageal ultrasound, transesophageal echo, which I'll abbreviate TEE. And this procedure is done similar to an endoscopy, if any of you have had that, to look at your stomach, but the probe going into the esophagus is able to look directly at the heart. And this is an extremely useful and accurate way to visualize the heart, because the left atrium is the most posterior structure of the heart. So you're literally looking right at the atrium. And what we will see is, in this instance, a blood clot. It's an echo-dense looking globular thing. And if this were to break off, this will easily float up into the brain and occlude a major artery. Okay, so how prevalent is atrial fibrillation? Well, if we look at, I like to do this by age group. This is works out better because patients often ask me how common. So if you're a 70-year-old, you can essentially bet that 5% of the people your age have atrial fibrillation. When you're 80, it's closer to 10% or more. So this is a common arrhythmia. The numbers currently in the US are 6 million people have atrial fibrillation, and this number is expected to double by 2030. And patients with atrial fibrillation, based on all of our epidemiological data, have a 5 times increased risk for stroke versus patients who don't have atrial fibrillation. And it has been shown that 1 out of 6 strokes is due to atrial fibrillation. So the other 5 are due to the hypertension and the cholesterol problem. If your cause is atrial fibrillation, the chance of a second stroke is very high. The other thing about strokes from atrial fibrillation is these strokes are very often large, massive strokes because these clots are large, so they occlude large blood vessels. So you may have had a friend, or maybe you know someone who had a so-called light stroke. So they had a stroke, but they really regained most of their function. That's very rare in a stroke from atrial fibrillation. It typically leads to significant neurological deficits, weakness on one side, being in a wheelchair, and the overall mortality is significantly increased. So the management of atrial fibrillation basically breaks down into 2 categories. So when I see a patient with atrial fibrillation, the first issue is the rhythm management, which we're really not going to spend any time on today. But of course, patients need their symptoms managed. We need to figure out, do we use medicines to control this atrial fibrillation? I will end up doing catheter ablation, which is a very effective procedure to cauterize or zap some of those abnormal nerves and normalize the rhythm. Now, the other side of the management, the other important thing is to deal with the stroke risk, which we've been alluding to, which involves anticoagulation. And this is really the mainstay of treatment for atrial fibrillation to reduce the risk of stroke. The medications, the time-honored one that was the only one we had for many, many years was warfarin or Coumadin. And as you may or may not know, this is a medicine that has a very wide therapeutic window. And what that means is that the dose that you take can have significant pharmacological therapeutic effects. So therefore, whenever somebody takes warfarin, they need their blood tested to check for the amount of blood thinning effect that they're getting. That's called the INR. So a typical patient on warfarin will usually need a monthly assessment of their blood to make sure that the dosing is right. Some patients are able to do finger stick checks at home with their own machine, but suffice it to say, monitoring is required. The other class of medications are what we call direct thrombin inhibitors. So this refers to the coagulation pathway, a metabolic biochemical pathway in our bodies where we form blood clots. These medications inhibit one of those steps, either factor 10A or thrombin. They have taken on a name which is called NOAC, which is a abbreviation for novel or new oral anticoagulants. And you may also see the term DOAC, which is direct oral anticoagulation. And as you can see, it really is kind of a meaningless term, but nevertheless, these medicines are lumped together being NOAC or DOAC. And these include apixaban, which is Eliquis, Pradaxa, and then rivaroxaban, which is Xarelto. There are 2 others, but the market is almost 95% is just these 3, mostly Eliquis and Xarelto. And the efficacy of these drugs is basically identical. They're all very comparable. So if a patient asks me which do I prefer, really the data is pretty favorable for any of them. There's some differences in the way they're dosed once a day, twice a day, and so forth, but they're all very effective. They are all as effective as warfarin, and in real life more effective, because the problem with warfarin is that patients may spend periods of time out of the therapeutic range, and so that's not an issue. With these medicines, you don't need to check a blood test for their efficacy. So there still are a fair number of people on warfarin, but the market is definitely moving more toward the NOAC type medications. Now, the risk of stroke is not homogeneous for everybody with atrial fibrillation. So we take atrial fibrillation, but then the stroke risk is amplified significantly by various clinical variables. And those are female gender, age over 65, another bump in the risk once you get over 75, high blood pressure, diabetes, any type of vascular disease, any type of heart failure. What that means is where you've had fluid on your lungs, that diagnosis, and then a prior stroke, of course, would seem to be intuitive. So these variables are termed the CHADS to VASC CHADS to VASC score. You don't need to remember this, but if anybody's heard of that, I wanted to make sure you knew where that comes from. This is just basically a mining of the data, trying to figure out, well, who are the people who have strokes? Well, the people, the more of these variables you have, the more chance you're going to have a stroke. So that's where these come from. And basically, once you have 2 or 3 of these variables, the stroke risk goes up significantly. So that risk can be on the low end of 2% per year. And as high as 15% per year. And remember, nobody just lives 1 year, so you can't say, oh, I only have a 2% per year. I mean, you have to basically say, well, I'm going to be hopefully alive for 10 years or 15 or 20 years. So that risk will basically accrue as a person ages with their atrial fibrillation. So now the other side of the coin, the mirror side of anticoagulation, is the bleeding risk. And there are well-known factors that correlate with higher bleeding, and those include uncontrolled high blood pressure, and those are people with major spikes in their pressure. You'll hear them talk about it. It's 120 1 second, it goes up to 190 an hour later. So those patients with labile high blood pressure, there's a risk of bleeding. They're at risk for the intracranial hemorrhage. And then anybody with chronic kidney disease, liver disease, a previous stroke, anybody who's really on other medicines. Let's say you happen to have coronary disease, you've had a stent, well, you're going to be on aspirin, Plavix, you may have heard of Brilinta or Effient, 2 other medicines. So those patients have an increased risk, age and excess alcohol. And so, as you can see from this, that ironically, many of the variables that increase your risk for stroke also increase your risk for bleeding. So whenever we make a decision, we sit down with the patient and we're always basically looking at risk versus benefit. So for example, somebody whose annual risk of stroke is under 2%, maybe mathematically there may be some benefit from a blood thinner, but their risk of bleeding outweighs the benefit, so we don't treat them. And then there are some people who the bleeding risk could be so high. Let's say the bleeding risk is 20% and the stroke risk is 10%. So we really can't treat them either. So just to explain that many things in medicine are what we call a shared decision making, where we basically go over the information and try and break down for an individual patient what their risk and benefit is of the treatment strategy. So regarding warfarin, one of the reasons that this medicine's fallen out of favor is just that the fluctuations in the INR needs to be between 2 and 3, where you get all the clinical benefit, but you have minimal bleeding risk. Under 2, you have no clinical benefit. And then over 3, you still, of course, have a benefit, but you have a high, the bleeding can occur. So these are reasons why warfarin has fallen out of favor a little bit, because patients often are drifting in between these various values on the INR. Now, an interesting finding is when the studies were published using Eliquis and Xarelto, of course, we see good efficacy reduction in stroke. But when further studies surveyed patients, what was found is that a fair number of patients really just don't take the medicine. For example, they decrease the dose if they're getting too much bruising, or they sometimes, just like a patient, you may forget your blood pressure pill one day, you forget your blood thinner pill one day. So the estimates are as high as 40% of patients are not taking their blood thinner for over 80% of the time. So they're quite exposed to the risk of stroke in that situation. And even in the studies that involve these three medicines, the discontinuation rate of these drugs was around 20 to 25%. So that is significant. And the major bleeding incidents were as high as 2 to 3%. Major bleeding has a specific definition. So blood in your urine is not a major bleed. By a major bleed, we mean either an intracranial bleed, which is a life-threatening, devastating type of hemorrhage, or a major hemorrhage where the blood count drops so much that you need a transfusion or you require hospitalization. And these bleeding risks, they tend to go up over time. So the stroke risk can be fairly homogeneous, but as people age and so forth, and other medical issues start to kick in, then the risk of bleeding tends to go up. It does not stay stable. So that has led to emergence of non-pharmacological strategies to try and mitigate the risk of stroke by addressing the left atrial appendage. Some of these have been done for many years surgically when a patient's getting open heart surgery. While the surgeon is doing bypasses, the left atrial appendage can be ligated. It can basically be removed and then oversewn, and so it's gone. So the idea that the left atrial appendage can be addressed has been around for a long time, but it's very much been limited to surgical patients. However, approximately 15 years ago, Boston Scientific was one of the first companies to develop a percutaneous catheter-based device which can be placed into the left atrial appendage to occlude the device, occlude the appendage. And the device has a fabric portion which traps blood clots, and then has an exposed nitinol strut portion, which allows the device to fixate on the inside of the appendage so that it is stable and holds its position. So this procedure is done in a cardiac catheterization laboratory, a similar lab to where we do other electrophysiology procedures or heart catheterization like angiograms. We insert a specialized catheter sheath through the vein in the leg, the femoral vein. This then gets advanced into the right atrium, and then we have a specialized catheter technology to cross into the left atrium, which is what you're seeing here. And then we advance a specialized sheath, which gives us stability, and then we deploy the device. And as you can see, the device is seated so that this fabric part covers the ostium, or the opening of the appendage. And then, believe it or not, over time, the body will cover over this. So this is what you'll see at the end of a period of 6 months to a year, is a lining of our own tissue, which coats this over. And this is basically what the body does. If there's a stent on the inside of an artery, it will cover it over. This is just a natural healing process. So a common question I get asked is, well, that sounds really fancy, Dr. McKensie. Is this new? And the answer is it's not new. It's been around for quite a long time, but these studies have rolled out very slowly, very carefully. The first studies were done in just a few hundred patients. There's always an issue with Medicare being very restrictive at first and wanting to see how the technology performs. Is it going to be too expensive, et cetera? But especially over the past 5 years, there's been a significant growth in these devices and these procedures, and the FDA has and the Medicare reimbursing portion, the CMS, they have all been very favorable for these procedures. The procedure takes 1 hour typically. It could go a little longer if it's a complicated appendage. We do it under general anesthesia with the TEE, as I was saying. The future, however, we will likely do these with sedation and not anesthesia. Currently, we keep patients overnight, but again, this is moving toward same-day discharge. The implant success rate is very high, 98.8% in the last study with the newest device on the market. So that was not always the case. Sometimes we would not be able to get the device in 6 to 8% of patients. And the complication rate has also dropped significantly. Severe complication is well under 1%. The typical strategy a patient will take, they will continue their anticoagulation. So let's say you're on warfarin, you're on Eliquis, you get the Watchman procedure done, you will continue the anticoagulation for 6 more weeks if possible. There will be people who can't take it at all, but if possible, there is a belief that that promotes better healing of the device and so forth. After that, patients are switched to aspirin and Plavix for anywhere from 45 days to up to 6 months, and then aspirin alone thereafter. So the goal here is to give the same efficacy of preventing a stroke, but to avoid having to take a blood thinner. So the discontinuation of anticoagulation is in excess of 95%, which is what you would expect. The device actually performs significantly better than warfarin for reasons that I alluded to. There was a 55% lower stroke risk compared to warfarin, and a 27% lower mortality. That mortality is lower because the large strokes were lower. So remember, I pointed out that these strokes are very large in atrial fibrillation. They may lead to death. Regarding its comparison to the novel, the newer agents, those studies are being conducted. So basically what we would say right now is it is a superior strategy to warfarin, that is the Watchman device. And currently it is equivalent to the newer agents, but those studies are being done right now. So who then is a patient, and this will be the last couple of slides that we would consider for a Watchman? Well, first, if they have non-valvular atrial fibrillation, and they have a few of those risk factors. So somebody who's like 50-year-old, no medical problems, their risk of stroke is very low. So the risk of the procedure doesn't really warrant it. But of course, 75-year-old, high blood pressure, diabetes, now we're talking high risk at that point. And then ideally, we would like them to be able to stay on the blood thinner for 6 weeks after. And then ideally, they would have, or typically they're going to have a reason why they want to do this. So I don't really, if I have a patient who is on Eliquis for the last 5 years and they literally have no problem with it, there really isn't a reason to go for a non-pharmacological treatment. So there really needs to be a reason to consider that, but I'll address that in my next slide. And then the last point would be a detailed conversation where we really discuss the risks and benefits and a so-called shared decision-making type of algorithm. In fact, usually we like to involve the other, like I'm an electrophysiologist, so I'm the super subspecialist, and I will typically take the input and discuss with the referring primary and cardiology doctor as well. So who are the patients? So group 1 is major hemorrhage. So these are people who are just fully contraindicated. So if you have a hemorrhage on your brain, you can't take a blood thinner again. It's just too risky. You got to play your odds. You got to say, well, my stroke risk is 5%, but if I take a blood thinner, I'm going to have another brain bleed. That'll pretty much be a fatal event. So that group is just off the table. Another group would be a spontaneous major hemorrhage. You don't really know where it came from. So for example, I've had patients referred to me where they've just had a spinal hematoma just came out of the blue. Or something on those lines. So, if there's no treatable reason, it could happen again. So no blood thinner for that person, we're going to do a Watchman. And then again, if major hemorrhage where the patient, let's say the patient has ulcers, but every time they get an ulcer, they drop their blood count, 5 points. So that's not going to work for the patient either. Now we have category 2, minor hemorrhage. And, if somebody has hemorrhoids, the treatment is to address the hemorrhoid. So these would be minor recurrent bleeding where they really can't do anything about it. A very common one is nosebleeds. Epistaxis is the medical term for that. GI bleeding, again, ulcers, we can treat them with medicines, but they can rebleed. And diverticular disease of the colon, again, is a very common cause for recurrent bleeding. We can't just do a surgical removal of the whole colon. So these people are at risk of bleeding. And then finally, people with recurrent hematuria, blood in the urine, that's bothersome as well. Now, the third category would be people who are likely to have problems. And this would be patients who are increased fall risk. Let's say you have Parkinson's disease, or maybe you just have terrible arthritis, somebody really with a walker and they're really at risk of falling. We don't want them to fall while they're on a blood thinner. That could be catastrophic. So that would be a group. Somebody who has an increased bleeding risk, I alluded to earlier, people that are on multiple medications that affect your platelets, aspirin, Brilinta we talked about, or maybe there's bad kidney disease. Dialysis patients are very high risk of bleeding. And then the fourth category would be, I'm going to use the term quality of life. And this would include people that just keep every time they bump into something, there's a big blotchy bruise on their arm. I've had patients who just walk by the doorway and, part of their skin sloughs off a little bit. It's, it's not dangerous per se to the patient, but it really gets old quickly. And then some people will just spontaneously get bruising. Some people, men, if they're shaving, every time they nick themselves, that's a 20-minute ordeal for it to stop. So then there are people, certain lifestyle, let's say they are an avid rock climber or a cyclist. Cycling is actually a real common thing that comes up. So there again, if they get an accident, it would be a problem. And then lastly, people that are just not that good with their medicines to begin with. They really don't like to take medicines. They're missing doses here. Maybe they're sort of a little bit forgetful. So that would also put them at risk. So a medical compliance. So those are the four. That's a common question. Who are the people that should be considered? It's these four categories. They first have atrial fibrillation, of course, and they have some risk factors. And then they have had either major hemorrhage, recurrent minor hemorrhage, they're at risk of bleeding, or it's a quality of life issue. So there are other fun things to talk about regarding atrial fibrillation and stroke and management and so forth. I'm going to I'm going to assume that Dr. Bader and Dr. Gregorian gave you a detailed lecture. If you're in the throes of having a stroke, of course, we want you to get to the hospital right away. You can have an intervention done. Regarding atrial fibrillation management, that's a whole nother area. And another area that is, discussion for another day would be detection of atrial fibrillation. We talked about this is a bad type of rhythm from causing stroke. And some people are asymptomatic. There are some people who their very first presentation with atrial fibrillation is in fact the stroke. So that is another area of interest. So lots of other areas to discuss, but I'm going to end the talk right now, which was in about 35 minutes. And I've got time for questions for anybody if they have any questions.